One tissue with great regenerative capacity is placental tissue, which serves the mother and baby with barrier properties and nutrient transport. Placental tissues are also readily available since they are normally discarded tissues. When you take a look at different tissue types, here there are 35 different tissues that are analyzed by microarray analysis. Microarray analysis looks at the expression levels of various biological mediators, and these are represented by a color tag. In this particular chart, you can see the red represents the highest levels of expression, and green represents the lowest levels of expression of the mediators that are seen on the right-hand side. And of these 35 tissues, you can see that placental tissue has the highest expression of all these 35 different tissues. So it's loaded with biological mediators that could impact on healing. The uterus and placenta are filled with vessels deriving from the umbilical cord, as you can see from this right-hand diagram. The amnion and chorion are the avascular tissues comprising the innermost layer of the placenta that directly separates the mother from the fetus. The roles of the placenta are several. Number one, it surrounds the developing baby, which is really a fluid-filled sac. It also serves as mechanical protection, allows the embryo to have free movement for growth and development, and it also protects from adhesions. The placental tissue also is immunoprivileged. It has anti-inflammatory properties, antibacterial properties, and is rich with growth factors and cytokines. We do a further, deeper dive into the placental tissue, into the cellular components of amnion and chorion. You can see that coming from top to bottom, starting at the amniotic fluid level, there's epithelium, basement membrane, more compact layer of collagen and fibronectin, then fibroblasts that are also filled with other types of extracellular matrix materials, and then an intermediate spongy layer. Beneath that is the chorion, formed up of a reticular layer, a basement membrane, and trophoblasts. These placental-based allografts all require processing. So from the time of the live birth, and again, traditionally, the placenta is something that's thrown away, but actually can be repurposed if processed appropriately. First tested for serological and microbial contamination, undergoing processing, and finally on the far right, the outcome is an allograft in a number of different forms. Number one is that unlike some of the other types of therapies and allografts that are available, these are generally shelf-stable, and once you remove them from their packaging, they're easily cut, easily manipulated, and placed directly on the wound. They tend to be adsorbed in, and the clinical results have been always quite impressive. Having said that, it's a reminder here that you can't just slap a placental-based allograft on any wound. You have to still do all the things that we do for modern wound management. Do you have a diagnosis? Can you address the underlying issue? Is it an inflammatory wound? Is it grossly infected? What's the reason why it existed? Are there biomechanical pressures that haven't been dealt with? So diagnosis is critical. And of course, everything else that we normally do in wound management still has to be done prior to using these. So that would include sharp debridement, routinely, which we do in almost all our patients, maintenance debridement with enzymes at home, possibly. Addressing the wound microenvironment. Is the moisture in the wound something that can be addressed using dressings that are either absorptive or provide hydration. Bacterial burden, not only is the wound grossly infected, but is there still an element of bacterial load within the tissues that could be better addressed using some type of antimicrobial approach, antimicrobial dressing, whether it's silver or iodine-based or any of the other types of modalities we have available. And finally, most patients have some comorbidities, whether it's venous reflux disease, whether there's some biomechanical issue that needs some type of offloading, improving perfusion. There's also, of course, nutritional status and all the other types of things that we have to address looking at the patient as a whole. And if these things are addressed first, you're likely to get the most optimal outcomes when you use an advanced modality like a placental-based allograft. So once the wound bed is properly prepped, then when you add a PBA, placental-based allograft, the data shows that these wounds do heal faster. In this case, this is a cohort of patients with diabetic ulcers that are either treated with standard of care or with the Purion process dehydrated human amnion chorion membrane. And in this study, you can see the massive difference in healing. Vertical axis shows percent surface area reduction. So complete healing is at 100%. 0 is at the beginning of the ulcer, completely open. And standard of care is the purple curve on the bottom. And you can see over this course of the 6-week study that the PBA allograft-treated wounds healed significantly faster, earlier, at all these different time points. This is to show you in some of my patients that we've had very good experience. This is a chronic wound in a patient that has multiple comorbidities. So those were addressed. The wound was debrided. Bacterial bioburden was managed. And then here you can see that we applied a Purion processed dehydrated human amnion chorion membrane. We do not do any fancy anything fancy in terms of adhering it to the wound. We just apply a primary dressing, a secondary dressing, and there's not much that needs to be done by either the patient or by us. And we see them back, we remove it, and if necessary, we can reapply. In some cases like this, even a single application results in improved granulation tissue. You can see this is at the first week of follow-up. It's nice and clean, nice exuberant granulation tissue. And that's followed over the course of the next few weeks by very nice epithelialization in the middle image. And at 1 month time on the far right, the wound is completely closed. So some of these wounds close very well just with a single unit of a placental-based allograft, while others, and these are on a case-by-case basis, can require weekly or bi-weekly applications. This is another example of a patient with a diabetic patient with a poorly healing wound, unhealed for over a year. And after providing the proper wound bed preparation, debridement, bioburden control, we then applied a placental-based allograft. And you can see in this particular case, we applied 3 sequentially over the course of a month. And you can see that led to complete healing. We've also noticed that these particular placental-based allografts are also something that just anecdotally seems to result in some reduction of pain. I hope what I've been able to show you is that we're in a new era that's based on regenerative healing. And we know quite a bit about the science. There's a lot more to learn, but the role of different cell types, the role of recruitment of stem cells from the bone marrow, all these are a new modality, a new insight into how we can heal wounds. The placenta tissue itself provides for a reservoir of these biological mediators for healing. And I hope I've been able to show you that the placenta is one of the most regenerative, highest regenerative capacity tissues in the human body, which makes sense. They're the things that really are allowing new babies to form and grow.